My name is Bree Jackson. I'm here today representing CalHIPSO, the Regional Extension Center for most of California. I think also in the room we also have High Tech LA, which is the Regional Extension Center for LA County. CalHIPSO is about 6,187 providers strong. A big question for us is Meaningful Use Stage 2 and how patient engagement plays into that. So I'm pretty happy today to have on the panel with me Sajjad, Yacoob, Jean Balgrosky, and Mark Branning. I made it. My first speaker is Mark Branning. He's the principal of MDB Healthcare IT Solutions. Mark has over 33 years of experience in health IT. He's managed HIEs. He's done extensive work around patient and consumerism, the thoughts behind it, and the impact on health IT. So without further delay, I'll introduce Mark.
Thank you. Great. I spend about 50% of my time with Scripps Health, where I'm doing several engagements. One of them is health information exchange. The other is patient engagement strategies. So without getting into a lot of detail here, patient engagement, we can all get our definitions of it, but we're trying to narrow it down to a specific area for this particular talk, which is you can go from patient engagement, a wellness class, I'm engaging the patient. It may or may not be IT enabled. The next one, telemedicine and mobile post-surgery monitoring. Well, that's patient engagement. That's using IT. But specifically what we're talking about in this thing is stage 2 in the meaningful use criteria. So this was, I borrowed this from David Rowe from Caradigm. This is a session from HIMSS, session 64 from HIMSS 13, and they had a whole thing about what people are doing about patient engagement. So on the top part, it's different things that patient portals and HIE and personal health records can affect. But on the bottom are the things that are really you're required to do now for stage 2. And there's only one that moves down, and that's the patient reminders. That moves down, but most people are fulfilling that from the EHR. So what we try to think about is how can we be helpful here by saying how are you going to fulfill these needs? So on the bottom there you see patient access, clinical summaries, patient education, secure messaging. So that's what I'm going to concentrate on. So I took it apart. I'm going to both show you textually and then try and give you a graphic on this. So how do we get patient access? Well, that's view online, download, and transmit. So that's the requirement. Well, you can have a patient portal that's tied to an EHR or EMR, a PHR that's fed from an EMR. You got to have a patient portal tied to an HIE, which is fed by an EMR. So there's lots of different ways. For secure messaging, it can be a function within the EMR, patient portal tied to the EMR, patient portal tied to the HIE and the EMR. And you could have a totally separate but secure messaging system. Clinical summaries, you can get that directly from the EMR. And usually, most people now are handing a piece of paper and now starting to make things electronic. And clinical summary is a patient portal that's tied to EMR, PHR fed, same sort of different ways you can do it. The patient-specific education, the requirement that the EMR suggests some education, and then you have to do something about that suggestion. Well, sometimes it's integrated with the EMR, sometimes it's a separate module interface to the EMR, a separate electronic module using manual entry. So the EMR suggests something, I can go to a separate one and I manually put the information in and generate something. And paper protocols individual for each patient's use. These are videos, these are handouts, etc. So given that, now I'm going to kind of show you graphically. So I'm actually describing San Diego here. But there's an IDN, Integrated Delivery Network. It's got its own HIE. So an IDN that's got its own HIE, it's got an ambulatory EMR, and it's got a hospital EMR, and it's got some lab systems, affiliated physicians, et cetera. And let's say there's another one in the area, and there's another couple in the area. And those might have patient portals. Those patient portals could be directly into the EMR, or they can be into the enterprise HIE versus the community HIE. And in San Diego, we also have a community HIE as part of the Beacon program. And 2 of these are already talking, and 2 of them aren't, but soon to be. So we have the community HIE. And we also have patient portals or personal health records that can be outside of that, independent of the portals. So this is, if you heard my talk earlier about the difference between a patient portal and a personal health record, this helps you understand that the personal health record gets data from all those organizations. Usually the patient portal is tied to a organization. So, but the community can also have a patient portal. It doesn't yet, and it can also feed the personal health record. So Scripps has allowed me to use their name. When I did this, I didn't know if I had clearance, so I said one IDN's way of solving this problem. So this is Scripps Health, and this is how we're solving it. Kelly, don't steal this, okay? So we are for the view online, download, and transmit. It's a separate patient portal, but it's tied to the 2 EMRs, so the EMRs are feeding that. Right now, just ambulatory. Secure messaging, that's within the patient portal, again, tied to the EMR. For the clinical summaries, that's all coming out of the EMR. So when they leave, the EMR is generating that. And the patient-specific education, we went with a separate module interface to the EMR. So the EMR is suggesting, but it's interfaced and then goes right in there and gets individualized for the patients. And I think we're going to hold questions, right?
Yes, we are.
Okay, so that's Scripps, that's the criteria, etc. Who's up? Right.
So good afternoon. It really is a pleasure to be here to talk to you about this. I think, as Mark pointed out, and you'll see from Gene also, this is clearly an important topic as we migrate and start to move towards more engagement of patients to help with their care. And I specifically want to call it out that it is a high-wire act of meaningful use because, you know, you're doing something that's going to be radically different. And in this vein, it was Andre Gil who said, "Man cannot discover oceans, new oceans, unless he has the courage to lose sight of the shore." And in many ways, the way we in hospitals and clinics right now engage our patients is a certain way that's been going on for a long time. And to be able to really have meaningful engagement that's going to be at a level of using technology and tools that we're going to have there, you're going to have to do something completely different. You have to have the courage to sort of go out on that shore, lose sight of that shore, go out in that ocean and try and discover what is out there. And so, as Mark pointed out, you know, there are these requirements that came out, potential impact. When you look at, I'll just take, for instance, these 4, you know, talking about patient access, clinical summaries, education, secure messaging. Those are a good starting point. And you can look at that. And so in our organization, we said, certainly we're going after meaningful use. We'll look at that as criteria at Children's Hospital to do. And when people looked at it, you know, it's sort of like, we had a meeting, we said, listen, it's sort of like magic. Let's just put the words in there, shake them up, and we'll engage. And the reality is that, as you know, that's not the case at all. And so just a quick background about Children's Hospital Los Angeles, where I'm at. We are a tertiary, freestanding, not-for-profit pediatric hospital. We have a lot of care going on, a lot of education, a lot of research. So a big factory from which to really learn from in terms of pediatrics and healthcare, especially in this new age. We've had the good fortune and foresight to try and work hard. We're a magnet hospital, for those of you familiar with the magnet designation for nursing. We've also been on U.S. News and World Report 15 years in a row. And the one thing that may be relevant for this group, we're at a HIMSS level 4.3710. And HIMSS, thank you for going to the 1,000th decimal. I think like Olympic running, we know that now. So it is an area that we certainly want to go towards and move along. And we certainly have, I think, at least the people who want to make that happen. But getting back to this point about engagement, when you look at these 4 areas, if you look at those just as they are, while there are details around how you do that, the important thing is these 4 areas for engagement really sort of start this way. Our strategy is very simple in some sense. I mean, Mark pointed out the complexities and details there, and I'm not trying to minimize this, but, you know, we said, look, let's take all these, put it into a portal, let's brand it, let's make it mobile, make it portable for the patients. Let's go ahead and connect it to our EMR. We have an EMR at our hospital that's used both in the inpatient and outpatient world. Let's go ahead and connect it to that. Let's make sure it gets connected to some patient education tools that we have. And that sounds like it's really easy to do, right? I mean, you just sort of think about it and say, let's put it all together, put it on here. People know how to access it. It'll be fine. The reality is, for those of you that are familiar, if you ever watched Star Trek: The Next Generation, anybody here fans of that? You can freely admit it, it's okay. Yeah, Star Trek: The Next Generation, you notice whenever there was an order done by Captain Jean-Luc Picard, he did two things, right? He first said, make it so, number one. And then what was the word he used after that? Engage, right? So for doing this, it is make it so, build what you're going to do. But the second part, which is the harder part, is to engage. And so I'm going to spend some time talking about what are those things we have to think about when we want to engage, because the technology and tools, I'm not trying to simplify it, but they're there. You'd be able to do that. You can find people, excellent people, Mark, other people who can go and bring it into you, but the organization has to own it. The organization has to be the one that does that. And so what does this mean to attain this from an IT perspective, but also that we have to look at through the lens of the patient? And so a couple of points I want to give to mind is, first of all, from a meaningful use standpoint, remember, I remind all of us in our organization this, meaningful use to engage patients, it's just the floor. It's the beginning point. The ceiling is much higher. You don't want to use that as your benchmark. You know, that old adage, you hit what you aim for. If you just hit the meaningful use criteria, you're going to hit something, but there's so much more to do with that. Second thing is, remember, everybody does this. You know, when we start our project, it takes, 6 weeks, 8 weeks, however long it is, 2 months, 5 months. When we finish, we think, all right, we're done. And the reality is, for meaningful use, especially in patient engagement specifically, the end of the project is really just the start of engagement. You're not finished with anything. That's when that engage starts to kick in. You built it by saying make it so, but now you've got to engage. And so from a patient perspective, we looked at it and said, this portal, while it's a simple strategy in some sense, we've got to understand what's going on here. There's a venue-driven design here in the sense that we know for our hospital, our patients are inpatient, but we also know that they go home. We also know that they go to an outpatient clinic. We also know, at least in pediatrics, they go to school, but in the adult world, they maybe go to work or wherever they happen to be. There's a whole venue here that we have to take into account when we talk about engaging patients. It's not just one place in time, as you've heard previous speakers today talk about. The other thing is, for us, from a technology standpoint, we have to understand a lot of the tools and things we use come in different places too. So our EMR, which we name KIDS, acronym stands for Knowledge, Information, Decision Support, that's one source of where we'd use our patient engagement. But we also have Apple, not the company, we didn't buy them, but there's a patient software tool for education called Apple. We use that in our hospital. We've got to make that as part of this cycle. We also have a patient entertainment system on our inpatient service called Get Well Network. We have to incorporate that into it. And certainly, we still use a lot of paper. We have to find a way to bring all those together. Again, the disparate things. I mean, thinking about what Pamela Lane said about 200 different data systems for foster care, we're almost like that. I just minimize it, but we have a lot of different places that we get information. We've got to bring that all together. And so when you think about it, what do the patients want? There was a Intuit poll back in January of 2011 that asked patients, would they go onto a site that was secure if they wanted to message their doctors? And 75%, not surprisingly, said, yes, of course we do that. But the interesting thing to remember, and this is where the business proposition comes in, 50% of those surveys said they would switch their provider to go to the physicians that had that secure messaging. So the incentive is there. So what do patients want? Well, patients only want something that's portable, right? We are living in this generation that's portable. They want something that's relevant. So don't just send me lab results. Make it relevant to me. And for those of you that are interested, if you ever, anybody go here on TED Talks, there's a great TED Talk by the editor of Wired Magazine, Thomas Getz. He talked about reimagining how we send data and information to patients that's meaningful and makes sense. And so make it relevant so they can understand it and be actionable on it. And the last thing is make this portal usable. Doesn't matter how great it is. If it's frustrating to get through, that's why I always say, if I had to start all over and I want to do healthcare EMRs, I'd have Apple design it, right? Apple gets it when it talks about usability. That's one of the key factors that people don't use things. If it takes 5 clicks to get what I need to, people aren't going to do it. So you want to make sure that it's usable from a patient perspective. And having said that, I think the biggest part about engagement, though, is you have to have sustainable connections. Just like you may have heard, those of you in this social media talk earlier, et cetera, you have to have a way of people making the human connection. Because at the end of the day, you engage patients not by the tools and the whistles and bells that you have, but by them the ability to make connection, to actually ask a question and get it answered, to be able to talk to their provider or their scheduler or their therapist. So this arc and connection that you want is not just to a physician, it's not just even to a hospital, but it's to people that the patient connects with and sees as valuable and useful. So sustainable connections as part of how you engage, the design that you go into is extremely important. Now, having said that, when we think about this, This immediately struck me. This was just 3 weeks ago. I was in grand rounds at CHLA. And our grand rounds start at 8 o'clock, so people come strolling in at certain times. And people do their activities right before grand rounds. And this is a picture that I took of one of my colleagues. He was sitting near the front, but he was catching up on the news of the day. Another colleague of mine, also sitting at the front, was catching up the news of the day. I tend to sit in the back just because I want to get out quickly. No, I'm joking. I tend to sit in the back because it's easier to see. But what I noticed as I was sitting in the back, when I looked to my right, here were 2 medical students, and they were catching up on their news of the day. And notice the discrete and utter difference between them. The fact is, for them, this is not technology. It just is. There's no use curve here. There's nothing else. This is what they expect. So one of the drivers you have to understand is, as much as meaningful use is pushing us toward this, if you didn't do it, I think the question that was answered before, what's the cost of having a phone? What's the cost of having this if you don't have it in your organization? And so, for me, just as a sum up saying, meaningful use is just the floor. The end is just the beginning, and use technology to enable human need to connect. The patients need to be able to connect to providers and clinicians to get answers, and engagement is just the beginning. And I tell all of our folks who are working on this patient portal project that it's not just something that we're involved in making happening. We have to be committed to making it happen for our patients. And everybody knows the difference between being involved and committed, right? It's like in the making of a ham and eggs breakfast. The chicken was involved, but the pig was committed. Think about it for a second. So if I had to sum up patient engagement in a couple of words, what I would say is this. When you think about the technology, you think about patients, I would say it's creating tools which are usable and relevant to the patient, which enable sustainable connections to providers and which create behavior change, right? That back to behavior change in patients that improve health outcomes. Because if I have a portal site and people visit it, but nothing happens, if the hemoglobin A1C doesn't come down, if the patients don't have increased vaccination rates, if I don't have decreased obesity, I've not accomplished anything by having a portal. All I've done is put information in another area that now they just have a digital trash can they drop into as they walk out of the patient's office. So again, we have to reinvent ourselves a bit. We have to do things differently. Even though the tools are there, the fact that we are engaging in a different way, we have to even think beyond that. Because this is not something that's going to change just because we put the tools up. It's going to change because we change the way we use the tools, and more importantly, a powerful tool nonetheless, but wield it with some caution and discreetness, but make it so that our patients are more engaged in that. So when we have questions, we can talk about this, because I think, again, the technology is vastly important, but how we wield that technology and connect to our patients is just as important.
Good afternoon, everyone. I'm going to try and tie this together and also get us to take a little step back and think about how do we even create this to begin with. It's one thing to have a new set of requirements for meaningful use, which is very, very important. But if when those new regulations and criteria are published is when you get started, you're way behind the curve. So what kinds of things do we need to be ready for any of these kinds of requirements? So really this involves 2 things, many things, but 2 things in particular for this discussion. One is, what's your health information technology strategy in your organization? And then secondly, what's your organization's culture and attitude and plan and goals and objectives for patient engagement? Those 2 things really are what has to come together to make this real. So the organization's IT strategy is foundational to many types of initiatives. And again, these kinds of strategies have to really be in place and being pursued in the long run with an eye towards the future. And your IT folks working with all of the key leaders in the organization who are responsible for clinical or business processes are the ones who spend time thinking about where will we be in 5 years and 10 years? And then how do we create infrastructure and systems that allow, when the next set of requirements comes out, allow the organization then to utilize those tools and infrastructures that are already available, to shape them and to create another instance of them to meet their particular needs in the way that they need to and want to. All right. So the kinds of things that IT people think about all the time and should have been working on for years in large health systems and a long time, relatively speaking, in physician practices and things, is we need networks, secure external networks and internal networks. We need core systems like electronic health records and good financial systems and all to meet our clinical and business needs. business intelligence and clinical intelligence, the ability to analyze the data and yield knowledge out of the data that are created and captured in those core systems, and then infrastructure to move all of that around to the right people at the right time in the right place in the right format. So both HIT strategies and patient engagement strategies should be generalizable enough and not so locked in or proprietary or specific that they cannot then, when a brand new need comes up, be generalized to implement that new requirement, and in this case, meaningful use stage 2. So hopefully the organization has been guiding itself strategically along the way so that as it's coming together culturally and actually gets an idea about how it wants to engage with its patients, either in their home or within the clinical settings, that the IT capabilities are there and just need to be shaped, and then really working in tandem between the clinical and the IT folks is how this happens best. Otherwise, the organization will be caught flat-footed, and that's not a good place to be. And catching up is very difficult to do with these systems and initiatives. So in summary, the IT strategy should be a direct reflection of the organization's vision and strategies, such as patient engagement. This is one of many, right? And that the technology infrastructure that's in place then can be generalized to meet those requirements when they become specific, such as they are now with meaningful use stage 2. So if we look at just a simple chart that shows these particular ones in meaningful use stage 2, we need to be able to have patient access and patient education and all the kinds of things that need to be in place to enable that, or to provide the tools and the electronic highway, if you will, to be able to accomplish that would be especially internet-enabled connectivity. So portals, intranets, extranets, and internet. Clinical summaries, that probably is more dependent upon your application software, which again, these core systems are things that your IT group has been working on for years that can be used for this and for many things. You can't you don't want to be trying to extract data from a new place just for one new need. It all needs to be coming from that core system so that it's consistent and has integrity with all the other uses of that data. So your electronic health record would be an example of that, and the clinical and business and other reporting and things like that you might want to use for your clinical reporting and summaries. And then secure messaging, infrastructure. We need good networks. We need great mobile computing now. We need the ability to know that our data can move around on these infrastructures with security and confidence that we're protecting our patients' information and being compliant with all the necessary regulations and all. So ultimately, we want to be able to allow patient engagement to emerge. We begin, as was stated earlier, this is an initial requirement. People have been talking about this for years and years, right? 10, 15 years. Because as IT and the internet became available in brand new ways, people, of course, started imagining these kinds of things from the get-go. But now the government has given us an incentive. So these meaningful use criteria are specific criteria that say, okay, if you do this, you get that, right? So now it's taken some definition and is the floor from which we need to emerge. So the IT people should always have been thinking about this. Okay, I'm talking to people, and they talk a lot about engaging patients and people, persons, consumers to this data and all. So I've been building out this infrastructure, which is generalizable, and okay, here's an instance, and then let's work together. Can't be just IT's project, and it can't be just the process owner's project, because they don't have the IT. So it's the two kind of married up together, which makes things work perfectly. So, and of course, people in IT, when you think strategically, they need to be, as Wayne Gretzky, I think, said, skate to where the puck is going. So this is just the beginning of patient engagement. So if we see here, and of course, we're not going to go through this, but only a few of these boxes are even tapped into with this small set of patient engagement initiatives and criteria. And this is from the February issue of Health Affairs. Patient engagement is a very complex and an evolving and a maturing kind of phenomenon that's going to take shape in various ways in various organizations as it evolves. So put this up here just as a reminder that meaningful use stage 2 is only the beginning, and there's a whole journey ahead of us, which ought to be pretty cool when we get there. So the organization's IT strategy is foundational. It takes many years to build up to comprehensive levels, and then it's a matter of translating requirements, such as these meaningful use stage 2 patient engagement requirements, into instances of use of the strategic HIT pillars that should already be there. If they're not, then I know some of you are from smaller organizations or from physician practices, but these systems are in place, and this is why many of the health systems now are engaging much more directly with physicians, and you know, so that these kinds of capabilities can be tapped into. All right.